What we see with the data set that was generated with larotrectinib is we're essentially defining a new type of cancer. Historically, we've defined cancers based on where they come from, and that's been very useful in developing effective treatment strategies for those various cancers. What we have here is essentially a new cancer diagnosis, which is TRK fusion positive cancers, because they define a group of tumors that are exquisitely sensitive to TRK inhibitors. So what I think we'll see is really an evolution of defining this as a diagnosis, using larotrectinib as our initial agent in this population, and then I hope to see a series of drug development in this population like we've seen with other genomically defined populations like ALK fusion positive lung cancers. And by really not only using highly effective agents up front, but potentially multiple agents over time, you can really prolong the benefit tremendously in that population.
So I think it's early right now to know exactly how TRK inhibitors are going to impact clinical practice in general. I think that most patients who are going to receive TRK inhibitors are patients who have been identified either incidentally or specifically because they have these rare tumors. That will lead to, whether a patient with a fusion patient and then been refractory to chemotherapy, like a colorectal cancer patient who's been refractory to standard chemotherapy, and then receiving this because they found this on an incidental finding in an NGS. But there could be other instances where, for example, a patient with infantile fibrosarcoma, which is a very specific disease, an NGS panel or some assay that identifies this patient truly to have an NTRK fusion, that patient could receive an NTRK inhibitor, and that could either lead to, either complete response, as in some cases we've seen in the trials, or even in one instance in this study where the drug led to significant reduction of that tumor and led to a favorable surgical outcome. So I think it's not clear what the prevalence of NTRK fusion patients are actually in the universe of tumors in general. But as NGS testing becomes much more a common thing, I think we will start seeing what the true prevalence is, and that may be higher than we initially thought. Again, I think it depends on the clinical situation. If it's a very common tumor, such as lung cancer or a patient with colorectal cancer, if available therapy does not seem to be working, I think at this point, if they identify this patient incidentally with an NTRK fusion, I think it's appropriate to treat these patients with NTRK inhibitors. However, in rare tumors, which either have no therapy or if surgery is the only option, this may be an option in these cases. For example, infantile fibrosarcoma or masked tumors, which oftentimes don't respond to chemotherapy. If they harbor the NTRK fusion, it may be of benefit to give those patients up front this drug, especially in the metastatic setting.
Obviously, with any targeted therapy, we're always worried about the possibility for the emergence of acquired resistance, patients that were initially responding and then eventually develop resistance. One of the fortunate things about this program is that we haven't seen a lot of this at this point in the larotrectinib program, and the drug really has demonstrated durable responses. But we have begun to see a few patients that do develop acquired resistance, and I think the experience that we're going to see in this space is going to mirror what we've seen in other oncogene-addicted cancers like ALK fusions or ROS fusions, where resistance is going to be mediated by one of two mechanisms. First, you can see acquired mutations within the TRK gene itself. And in the initial paper that we published, we presented data from the first 9 patients who developed acquired resistance, and all 9 of them had a detectable new mutation in the TRK fusion, equivalent to kind of a gatekeeper mutation we've seen with other diseases. And what I think is really important about that mechanism of resistance is that it is potentially amenable to newer classes of agents like LOXO-195, which are rationally designed to not be interfered with by these acquired mutations and could continue to generate or salvage responses in patients that have lost sensitivity to the earlier classes of agents. And then we do think there will be a population of patients who develop resistance on the basis of so-called bypass tracks, where other growth pathways become activated, potentially in parallel or downstream of the TRK signaling pathway that leads to regrowth of the tumors in the way that may not be addressed by drugs like LOXO-195. Those patients actually may require drug combinations, and that's also an area of active investigation. But we're going to learn a lot more about these as we get more experience with the use of the first generation of TRK inhibitors, specifically larotrectinib, and as we get more experience with LOXO-195 and just more patients are treated with these agents.
Once these TRK inhibitors are approved by regulatory agencies, I think we're going to need to very seriously think about widely screening for these NTRK fusions across different solid tumors. We know also from the data in pembrolizumab that was approved by the FDA for MSI-high cancers of any solid tumor type, that this is a molecular signature that can be found with comprehensive profiling. And so I think that we need to come to a point where both regulatory agencies and payers buy into the concept of doctors screening for these molecular signatures in order to get these patients these highly active therapies.